Plumas County Public Health Agency, growing healthy communities.
My name is Matt Curtis. I'm with the Office of AIDS at the California Department of Public Health. My work is basically to help expand access to harm reduction services all around California. I've been working with the folks in Plumas County since before they got their syringe exchange program started. I'm working with some of you that are in the room otherwise. So it's great to see people, and I'm really happy to be up here. We're gonna introduce the rest of our discussants in a moment. I just want to start by saying, that was a really beautiful statement from our friend Dan Bigg a moment ago, and that's the stuff we want to use this session to unpack. So the purpose of this opening is really to kind of talk through what do we mean when we talk about harm reduction? What does that mean in terms of practical services? What does it mean in terms of the approach that we're taking? And in particular, I want us to kind of think through how this relates to a lot of things we're already doing and that are already really familiar with us in other contexts of our public health practice, how we do medicine and nursing, how we do social work, how we think about the basic way that we want to interact with other people in our communities and what kind of communities we want to build. The other thing I want to really emphasize is even though we have a dark room and bright lights that make it hard to see some of you, we want to make this really interactive. And so it's the first session, it's in the morning, you're still getting caffeinated maybe, but we're going to have questions to the audience. And I also want to encourage everybody that if there's something that comes up in the conversation that you have a question about, there are no wrong questions. There's no right way to ask a question. Just ask the question and we will all deal with it together. We just want to kind of have a little bit of a back and forth to get some of this stuff out. So you're welcome to interrupt. You're welcome to raise your hand at any time. We want to just we're going to have sort of a guided conversation through this stuff. So I'm going to pass the mic around and stretch it and just ask our discussants to oh, you've got another one. Okay, to introduce yourselves real quick.
Hi everyone, good morning. My name is Rachel McLean. I'm the Chief of the Office of Viral Hepatitis Prevention at the California Department of Public Health, and I'm just super, super excited to be here and very grateful to you all for opening up your beautiful town to us, so thank you.
Hi, my name's Libby Guthrie, and I'm the director of the Mendocino County AIDS Viral Hepatitis Network, and we've been involved in syringe exchange since 1998 when it was still underground, and have been locally authorized since 2000, and then got our real authorization, so to speak, I guess in 2006. But this is a really amazing. I was so thrilled that we were focusing on the rural issues, which are essentially the same, but very, very different in operational ways. Thank you.
Good morning, everyone. My name is David Showalter. I'm a PhD candidate in sociology at UC Berkeley. For the past 18 months, I've been doing research on opioid use and services for people who use opioids in a number of mostly rural counties in Northern California. And I also serve as the president of the board of directors for NEED, which is the syringe access program in Berkeley. I've been doing harm reduction for about 9 years, first in Chicago with the Chicago Recovery Alliance and Dan Bigg, and now in California. And it's really awesome to see all of you in Quincy today.
I'm Brandy Wilson. I'm the director of Humboldt Area Center for Harm Reduction. We're a community-based harm reduction organization. We heavily rely on people who use drugs to tell us what to do and how to do it, and that has created a flashpoint in our community, of which we started apparently.
We can talk about that more. So thanks everybody. So the first question is for the audience. So, James had that nice map a few minutes ago showing that we have, a pretty big stretch of territory that people have come from. We've all made it to Quincy. why are you here? I kind of want to get some immediate guidance from you guys. Like, what are you looking for? I know there's things that I'm looking for help with that motivated me to come here. And I wonder if anybody's got any quick reflections on that. What do you want to get out of this? What are you struggling with back home in terms of trying to start something new or expand something you're already doing, or a question you have? And we don't have mics for the audience, so you just got to yell it out. Up front.
So a big thing would just be the attitude in the community, so stigma. That's what we're hoping to get a few ideas.
Yeah, so pointing out stigma is a kind of ongoing barrier to stuff you're trying to do. And please introduce yourselves when you speak. Thanks. Who else?
Can you repeat their questions after they say it so we can hear it? Sorry.
Yes, so again, that was just trying to address stigma in the community. Yeah.
Thank you.
Sorry.
I'm Jessica from Siskiyou County. I guess on how to start conversations with an everyday person. I'm going to be going out with a van hopefully soon, and I want to be comfortable, with the stigmas and with my own reservations, and for me to be able to start a conversation and saying, how can we improve your life?
Yeah. Could people hear that? No. Okay. Sorry, everybody. So how to kind of bring messaging or to talk to folks who are not engaged in this work in the community to sort of get the point across and make connections and actually get the work going in the community. Others? Yes. Speak up good and loud so I don't have to repeat you.
I'm Angel. I'm here representing the Research Center here in town, and I'm here because before social work, I was a pharmacy technician, and I felt very enabling for the population and kind of helpless in helping a problem that I saw evolving every day. People would start coming in for more and more stuff, and I just gave it to them. Didn't question it, wasn't really able to do anything. But now in social work, I'm able to kind of take control of it, especially at the Resource Center, where we see so many people on a daily basis that are in such need. So it's really powerful to be here, part of it to help the most needed people.
Thank you.
I wanted to make a comment.
Oh, sure.
One of the questions or comments was about comfort level in speaking about harm reduction, and also if you have your own reservations about it. I think that not having any reservations about it whatsoever, still, it can be a really, really hard conversation to begin, particularly if you're very, very polarized. And I hope that some of these kind of conversations happen today, because even myself at times I go, is this the moment? Is this the time, that I can bring this forward and talk about it in a common sense way? And you can start as simply as brushing your teeth is a harm reduction measure. Let's talk more. I mean, but it's not simple even if you're very well informed.
There's another.
I was just going to add to that there's a session this afternoon that Alessandra Ross will be leading on how to respond to objections to harm reduction. So if you would like to attend that session, please do.
I saw a hand up right here.
Yeah, Susan from Lake County, and I'm here because I want to learn the strategies that have been successful.
Great. That is a good one. So yeah, I think this is good. I'm hearing a lot of themes around just not knowing kind of quite where to begin, and recognizing that there's this huge baggage we're carrying around from the last 100 years in the United States, and how we've addressed drug use through public policy and law, and how do we sort of chip away through that to do some other things we want to do in our local communities. And then this recognition that, in fact, there's a long history. There is a 30-year history of things happening that have been called harm reduction. There's probably a couple thousand years of history of other things that could be called harm reduction. So there is this, there is no need to reinvent the wheel. But let's just kind of dive into it. So Libby, you've been helping run this program for 20 years now in and around Ukiah. 15
for
okay.
me.
Well, the program has been there for a while.
Right.
And so, you have been, running harm reduction services in this small town in a much broader, rural landscape. What is harm reduction? When you say, we're a harm reduction organization, what does that mean?
The acceptance, embracing, if you will, of people who are actively using, and non-judgmental gets used a lot, but it's really not just a thought, but an action that embraces people and allows them to feel comfortable coming through the door. They do not have to have intentions of getting clean. They only need to be able to come through the door and at some point make a connection to be able to utilize the services. And I think that harm reduction is having a sense of self and dignity, regardless of what stigma is attached to your behavior. And I think people working in harm reduction, fully working and embracing it, understand that there's behaviors that go along with active drug use, but they're on a spectrum as well. Some people manage their drug use very effectively, and it may be harder for those people to quit because they don't actually see damage, if you will, in their lives yet, or not. Anyway, it doesn't require abstinence. It requires a person connecting to the safety, to the comfort of not being considered others, but being considered part of the larger society. And I believe that's probably the most important piece, is people not feeling ashamed of what they're doing, but being able to have an environment where they can weigh the pros and cons of their current life versus the life they would like to see at some point, with or without drugs on board.
Yeah, thank you. Brandy, I wonder if you could maybe expand on that a little bit, and because you founded a harm reduction program in the relatively recent past, and so kind of what else would you say, kind of beyond what Libby just touched on, and maybe what's the contrast for what people are able to experience at Hatcher or in another harm reduction program that you're familiar with that they couldn't before?
Lots of things. Everything Libby said, and by and for drug users. If we don't include the people that we are trying to serve, then we miss the entire point, and we're just practicing good public health. Harm reduction includes the people that we're trying to serve because they are their own best source of information. And the more that we include the voices that we're trying to serve, the better our programs will be, the better connections we make, and the better we're going to be able to get the needed information into the places it needs to go. Like, I don't know dude's drug dealer 3 times removed that might be her drug dealer too, but that guy needs fentanyl tests. The best way to get all of that there is by the people that come in to Hatcher or to any other program or that go to a van. And for us, and I see it not just for us, I see lots of other organizations, a lot of community-based ones. It's also addressing the bad policy and the stigma. Because if we don't include drug users in that too, then we're just sort of doing it for them because they can't, and they absolutely can. We have had numerous political actions where people who use drugs have been in protests, have helped us create strategies. Drug users aren't necessarily what we think and what we see, and so They're actually doing it every day in all sorts of places, not just in harm reduction, because people use drugs all over the place. Well, I'm rambling. What's the other question?
You're doing good.
Okay.
So I'm going to kick it over to Rachel. And I mean, one thing, kind of I'm picking up a lot on is this idea of harm reduction as a way of doing public health in deep collaboration with the people that you're serving. Rachel was one of the founders of the DOPE Project, which is the kind of internationally renowned mass naloxone access and overdose prevention program in San Francisco. And I wonder, through that experience or, other stuff you've worked on up through and including, your work at the State Health Department, how that kind of notion resonates with you, that collaboration in how the work happens and how it's effective.
I mean, I feel sort of moved to just talk about sort of what got me to do this work in the first place, which is that when I was a runaway teenager, when I was 14, I was living on the streets in San Francisco, and this was in the very early 90s when HIV was still really recent and the prevention strategies weren't, it was kind of just condoms and bleach basically, and there were outreach workers in the Tenderloin who were working with homeless youth, and whenever they saw me, they would ask me over and over and over again, like, do you have condoms, do you have bleach? And I'd be like, first of all, I use lots of drugs, but I don't inject, so I don't need bleach. And I literally put a safety pin through my ear and hung a condom on it, so that, I'm not kidding, so that they would stop asking me if I had a condom. Because I'd be like, look, yes, I have a condom, thank you very much. And I had rolls and rolls of lifestyle condoms. And I also was engaging in high-risk sexual behaviors because what I needed, and the reason that I ended up in dangerous situations is that I didn't have any blankets and I didn't have candles for my squad, so I couldn't see. And I didn't have any blankets, which meant, how was I supposed to stay warm at night? I basically hooked up with somebody who had a sleeping bag, right? So my sexual risk was tied not to my lack of condoms, but to my lack of blankets. But the program that was serving me believed that giving out blankets was enabling people to be homeless. So I feel like, basically, 5 years later, when I wasn't on the streets anymore, I was like, okay, I want to be an outreach worker. I want to work with homeless youth and really listen to them and find out what their needs are and give people what they need and not what I'm funded to give them, and not focus on people as vectors of disease. And it's, I work in public health, and we are focused on disease prevention and overdose prevention. But the reality is that if we don't really listen to people and what are the actual determinants of their risk, then we're not going to make any progress. I don't even know if that answered the question, but I feel very strongly about that. Yeah.
And David, you're doing ethnography all over, a big chunk of Northern California in rural spaces. You've got your long experience in harm reduction in urban environments. I don't want you to spoil your own breakout session. But I wonder, kind of for the question we're dwelling on here of just what is harm reduction, what does it look like? Maybe even in places that you're, working with people who use drugs or service providers who are figuring out little pieces of this right now. What does harm reduction look like in these spaces right now? Because I don't want people to kind of have the idea that, harm reduction only exists where there's the syringe exchange program and there's nothing else happening anywhere. Because that's not true.
Yeah, I'm not going to spoil the breakout session. I'm just advertising it for anyone who wants to come. So I kind of think of harm reduction in several ways. So on the one hand, it's just a very pragmatic recognition of the fact that many of the things that people do, especially when we're seeking pleasure, are risky. And there are examples of that all over the place. So if you live in Quincy, every Saturday night during the spring and summer, you hear the Speedway, you hear the races at the Speedway. And it's dangerous. You just have to look at the cars to know that they've crashed a lot, and there are crashes routinely. But what's sitting right at the center of the Speedway is an EMT team ready to run over to the car when it crashes and make sure that everyone's safe. Same with having a fire extinguisher or a defibrillator in your office. It's a recognition that everyday life is risky sometimes, and that getting people to stop taking risks altogether is oftentimes just going to make them push them into riskier situations. So I think if you're trying to get over your own reservations or try to find ways to connect with people where there isn't a syringe exchange program that's been in your town for 30 years like there is in Berkeley, just look around and look for the ways that you and your friends and your loved ones are mitigating risk in your everyday life. Those are examples. But there is this piece that I think is really important, that is that people are the experts of their own lives. People are the best experts of their own lives. And that's true across a lot of experiences. If you want to know what would keep people safe who are using drugs, you need to talk to them. And it might surprise you. I mean, I think something that comes up a lot for the folks that I hang out with is that, we talk a lot about being far away from services that people need. Well, if you're dependent on drugs and you live in a remote community, that probably means you're also far away from the drugs that you need to stay well every day. And that the choice for you every day is finding something to keep you well, or being so sick that you're unable to engage in any services whatsoever. And so that means that people are spending a huge amount of their time, I would say probably way more than in cities, seeking and organizing and finding the money for and the resources in the car to get somewhere where they can get drugs. And that's going to preempt any other decision they make about whether to go to the syringe program, whether to go to the appointment that they had set up 3 weeks ago that now means nothing to them. And if we don't, get down on the street and, in people's homes sometimes to understand what their realities are like, then we're going to miss those pieces. And that's something I think really surprised me coming from an urban area, is the role that distance plays, just as one example.
Thank you. So I want to kind of turn to unpacking the practical impact or the public health impact of this work for a second, because that is something we all do need to kind of be squared away on. It's the first thing we often talk about when people are challenging, why do you want to do this? Why do you want to do these things that are, quote unquote, enabling people who use drugs, or what other term they might use for them. And so, one benefit, I guess, of all of this controversy over the last decades is that as a movement, we've been forced to rigorously evaluate ourselves and have other folks evaluate our programs over and over and over again in a way that is perhaps unfamiliar to other parts of public health or medicine, but is good in the sense that we have looked at most nooks and crannies of how these programs work, and in particular as they relate to infectious disease. So I kind of want to just make sure we're all clear on that to start with. And I wonder, Rachel, if you could start a little bit, particularly talking about the frame of this conference is around opioids, but we know that overdose is not the only thing we're concerned about, and so what else are we applying harm reduction to, and how is that working?
I think, my understanding is that harm reduction, the way that it started in the US, is that there was a woman named Edith Springer in New York who was looking for a therapist, and she was using drugs, and the therapist said, I can't treat your mental health until you stop using drugs. And she just was like, that doesn't make any sense. That's not my primary issue. And that sort of prompted this whole philosophical conversation about how do you meet people where they are. And then the HIV epidemic hit, and in New York City and in other places, people who use drugs sort of quickly, at first when HIV started, right, we didn't even know how it was transmitted. And then it became clear that it was sort of blood, bodily fluids, and quickly people who use drugs and other activists started handing out needles so that other people could inject drugs safely. The evidence is very clear. If you look at New York City, and the rates of HIV among people who inject drugs were very, very high at the beginning of the HIV epidemic. And then needle exchange was implemented and the HIV rates dropped. It's very clear that it works. And in Australia, when HIV was first sort of emerging, they looked at that and they were like, hey, what if we just implement needle exchange far and wide from the very beginning? And basically HIV just never took hold among people who inject drugs in Australia because they took a real comprehensive preventive approach. So we know without any doubt that HIV prevention through needle exchange works, basically. We also know that medication-assisted treatment, maintenance and not detox specifically for opioid use disorder, specifically methadone and buprenorphine, but really effectively reduce the risk of overdose, and they also reduce the risk of hepatitis C by 50%. There's a cute little infographic that I put on the tables. I'd love for you to take some. So we know that that works. We also know that getting naloxone into the hands of people who use drugs really works, and in particular Dan Big, who we heard from earlier, in 1999 in Seattle, sort of just put a duffel bag out of naloxone and said, I don't know where this duffel bag came from, but you might want to look inside and see what's happening in there. And that's how a lot of underground overdose prevention programs started in the United States, including in San Francisco. So again, we know that naloxone distribution works. It's really very simple. In San Francisco, when we started doing naloxone distribution sort of above ground, and they've been going on underground for a long time, our goal was to reduce overdose deaths in San Francisco. If you look at the data, it shows very clearly that overdose deaths decreased once we started giving out naloxone. What we've also seen in San Francisco is that as fentanyl has come on the scene sort of more recently, because people in the community already have a high saturation of naloxone, like to the point where drug users are like, leave me alone, I already have naloxone, stop offering it to me. When fentanyl came on the scene and there were people who used speed who didn't even realize they were using fentanyl, there were a bunch of fentanyl overdoses, and then everybody in the community sort of mobilized and made sure that all the meth users had naloxone. And what could have been a much higher death rate just didn't happen because naloxone has already really saturated the community there. And we know that the rates of overdose deaths are lower in places that have naloxone than they are in places that don't. So those are just like a sprinkling of examples. But I also I feel like there's sort of the biomedical interventions that are sometimes described as like what we mean by harm reduction, but I think there's also addressing the systems that are making it difficult for people to stay safe that I think is also part of harm reduction, and also what others were talking about in terms of the quality of the way that we interact with people, that also I think has its own effect that can be more difficult to measure, but that really matters, because we know that if people feel like they're going to be judged, there's a lot of research in terms of racism and discrimination, specifically in the healthcare system, that if people feel like they're going to be judged, they're not going to access care. So there's both sort of quantitative data in terms of biomedical interventions, but I think there's also a qualitative piece that I want to hold on to, that it matters how you treat people and not just that you offer them treatment.
Yeah. Thank you. And I was at a harm reduction event in Oakland last week, and there was literally someone with an earring with a vial of naloxone on it. So at least in some places we are irritatingly reaching saturation. So not even making that. Yeah, I mean, one thing that I would just add to that is that, unfortunately in the United States, in most places, we're not even seeing what kind of a complete harm reduction program looks like, because we don't have robust funding or integration with the broader healthcare system in most communities. There's a sprinkling of cities in the United States that have done a pretty good but still unfinished job with that. And so, but I think, one thing to kind of keep in mind about the effectiveness or practical kind of impact of harm reduction is that it's not limited to, we're kind of most known for syringe access, maybe medication-assisted treatment for opioid use disorder, naloxone for sure, maybe a few other things. But programs routinely incorporate mental health care services, case management or healthcare coordination, however you want to describe it, all kinds of community organizing, like all kinds of other stuff that does have this sort of collective impact that's sort of difficult to measure sometimes. But I think we do have, an increasing amount of good qualitative data and studies that have been done. We have the CDC saying, as part of their kind of core statement on harm reduction services, like participation in syringe exchange greatly increases an individual's average likelihood of entering drug treatment, for example. So, and that's not because of the syringe exchange, that's because of the whole environment that's built around that person's experience in the program. So kind of building on that practical impact, I wonder if any of the rest of you could talk a little bit about, like, we just kind of heard an overview of sort of the historical impact, the New York City going from 56% HIV prevalence among people who inject drugs in 1990 before syringe exchange to about 3% today. But on the sort of day-to-day, or even, at the level of abscess prevention or other stuff that kind of, people are seeing in the moment, like what do you see as the practical impact of your work?
I wanted to say something about the point that you just made about the need for comprehensive programs and how only a few cities have managed to do that. And I think going back to one of the themes that James mentioned in his introduction, like there are actual strengths in small and rural communities for building comprehensive programs, because it's a smaller group of people that you need to get on the same page to get things done, and one person can have a huge impact. So, one of the breakout sessions today, I think, is going to be talking about the really amazing work that Plumas is doing, getting naloxone into the hands of people getting out of their jail. That's people getting out of jail are the ones who are at the highest risk of fatal overdose. They're the ones who most need naloxone, and hardly any jails across the country are doing it. And ironically, the biggest jails have been the ones oftentimes dragging their feet. And I think in small communities you can really take a leap on those programs because it's easier to organize. And the other dynamic that I'll say, coming from running a program in a city, in Berkeley, we have a needle exchange, and everyone else says, okay, the needle exchange is going to handle all the harm reduction, and there's no real community buy-in around a lot of those programs. If you don't have those programs, if they haven't been around for a long time, then everyone needs to be bought in, because it's still everyone's issue. So I think in a small community where you don't have one organization that you can push all the work off onto, it actually enhances the ability to have, collective impact and collective engagement. Sorry to derail your question.
No, that's great.
The interesting part is how the community, what you said about the community sort of saying we have our syringe exchange and we don't really need to be involved because they're taking care of this issue. We're the only exchange in a 3,500 square mile, very mountainous, rugged area, and once upon a time, we only served people in Ukiah, right in the immediate area. And then eventually the Office of AIDS got involved back when there was prevention money in the early 2000s, and we had quite an infrastructure, and we were subcontracting with public health, and they didn't help us with supplies. We had to get those from private foundations, but we were getting testing supplies, and we had staff, and we had outreach workers, and we built this infrastructure. And we went to the farthest reaches of the county and had something going on, and then money just stopped. We dwindled over the years, and then the money stopped. And interestingly enough, our local public health department didn't know that we forged ahead. And it was only 2 years later at a meeting that they found out that there was still a syringe exchange in the community. It was just an in-house exchange using secondary exchangers that we had built relationships with when we had an infrastructure all over the county. And to this day, many of those people are still helping us, but it's been a real struggle for the last 10 years, and very quiet. Not public, not the public support or buy-in, people knowing that we're there and that we do that, but they take care of it. And so really, only very recently, in the last 6 to 8 months, have we gotten a new public health director who was open and wanted to listen and hear what we needed to address this opioid crisis, which, by the way, has been going on for decades, but because of incidences that have happened in other parts of our country, it's now front page news and more people are buying in. A lot of things came together that really helped us in our county, and that is things like the opioid crisis, having somebody new at public health, and unfortunately having to say in public, when the money disappeared, all the support walked away from us. So I've been funding the exchange for the last 10 years, no outreach staff, using people who use drugs and community events and piggybacking on the back of other homeless service grants we got to do the kind of outreach we need. We're not touching, but 65% of the people that exchange with us, we never get to see. So we don't get to touch them. And we have an HIV care management program, and we have mental health care management programs, and we have a hepatitis C provider who now takes people directly out of our in-house exchange and tests them and treats them. But these are all things that there hasn't been public awareness about. And in a lot of ways, that was good because we could just continue without a lot of public outcry so there's a good and a bad and a balance there. Overall, I feel like it's been beneficial that we've gotten more public awareness, but literally for probably 20 of the years of the 22 or so that we've been around, they just knew it happened somewhere. Just like HIV services happen somewhere. It's none of our business, and the hepatitis, So anyway, I'm rambling on, but I just wanted to make that point that oftentimes it falls on one place or, one provider.
I just heard something real
Yeah,
quick.
go for it.
It's quick. So they were talking about, the community being like, oh, there's an exchange over there, they're doing all the harm reduction. What's interesting in our community is that there's this outcry that the public health department is doing a exchange van. That's enough. We don't need you. We don't need your advocacy. We don't need to hear from drug users. And so I think it's interesting that in some communities, like, you're good, you're over there, we only need you, and as long, be seen, not seen or heard, it's fine. That is what we expect of people who use drugs. We don't want to see you, we don't want to hear from you, and if we do, then you're a problem. But as long as we don't see or hear from you, it's good, they've got it taken care of. So that's...
Yeah, and I mean, just sort of one thing I'd reflect on with some of the stuff that you guys are talking about is, I think in a lot of contexts, and I'll just say, in working in government now, I think there's been a history in a lot of parts of government of really wanting to fly under the radar with this stuff. In a way that is, in the short term, sometimes makes it easier to kind of get along or keep things going, and in the long term can be pretty counterproductive because it means that you do miss opportunities to build connections with other parts of the healthcare system. We don't want harm reduction to be a ghettoized healthcare services for this particular class of people who are unpopular. We want excellent quality healthcare services for people who use drugs and who have other things going on in their lives, whether they are related to their health or not. So I think that's particularly in relatively resource poor locations, where there's not a lot of funding for this kind of stuff, where there's not a lot of funding for healthcare infrastructure in general. It can be an easy, I'm not saying it's a trap you fell into, but it's a phenomenon that can sort of, is a little predictable in some cases maybe, and something for new people that are starting out to maybe be cautious about. But back to the good news about harm reduction. I wonder, just kind of turning back to the audience, I wonder if, we've kind of talked about the practical impact of harm reduction. We've talked, I think, I wanted to have a whole separate section kind of talking about the morality of harm reduction and how that is informed by other things we care about. And I think we've touched on that all throughout already. But I wonder does this resonate with folks? Does this sound like stuff you're already doing on some level or something you're trying to start doing?
here at PH. I just want to say that I think we work really well here at Quincy together. We are part of a coalition, but as a facility, I work in our hospital, but you know, we have mental health on board, and we have our county jail on board, our providers and our pharmacies. We all work together to do harm reduction strategies, not just through public health and through the county. So we even really enable our pharmacists to do harm reduction through naloxone co-prescribing, and that's really actually, I know Karen and I have spoken multiple times about how that's really made her feel empowered, and not just feel like she's always providing opiates to people who she sees and feels like are risky and that, you know, they're co-prescribed benzos and opiates, but she feels like at least then she can contribute to doing that education in the Narcan, and then she gives that feedback to us as well, that she's then prescribed that Narcan and done that education piece for the patient. So, you know, I think that's really been positive for us too.
That's great, thank you. Right there in the middle.
I enjoyed all of you. Thank you very much.
We're not done.
I'm so excited right now. I just wanted to say, so I like Rachel, was our awesome testimony today. So I come from, you know, the using community and homeless for many years, and now I get the privilege of being alive, one, and being a provider of services, two. Super sweet deal. I think that spaces of harm reduction do another thing. I know we're all interested in the public health interventions, but there's something very human about these spaces in that it's radical inclusivity for people who use drugs, and that does something to you. It plants a seed that empowers you to start making more rational decisions about yourself and others. It invests you into your community, and it invests your community into you. You actually have a group of people who care about you, who notice when you're not around, who care about the wounds on your flesh that they may not be looking so good. It's a space of, you know, like I said, radical inclusivity and a caring community. And even though we're the redheaded stepchildren of kind of the treatment and prevention world, and we are kind of on the margins, we provide that space for people that truly are on the margins, and I just think it's so awesome that we're all here today.
You nailed it.
Right there.
Excuse me. My name is Eddie Floyd. I'm not here as a reverend or a doctor, although I am both. I'm here as a radio talk show host, and I'm here as a student. I love your share. I have a talk show on addiction every week, every Tuesday. Okay, it would be on at 10 o'clock, so today it's not running, obviously. But I want you to know, I want you to keep two things in mind. I work for Harmony Mountain Professional Services as a counselor / doctor. I also am a talk show host, and I'm also the major stockholder of a worldwide media company called America Matters Media. Now, I say that to you not for any other reason than to let you know I'm here as a student to learn. I want to hear Rachel's story again on my addiction show. I would love to hear your story again on the addiction show. I would love to hear any and everybody's stories where they might be able around the world. We're heard on several terrestrial signals nationwide, coast to coast, border to border, but what you need to remember here in Quincy is AmericaMatters.us. That's AmericaMatters.us. If you click on that and click on the Listen Live button, you can actually call into the addiction show, share your story, or share an idea with the people. Our goal is to save as many people as we can, or help as many people as we can, because we're very fortunate. On average, we hit around the world 12.9 million listeners every month. So we have the capability of getting our
Okay,
Works out.
thank you very much.
Anybody who would like to call in and get involved with that radio show is absolutely free. We're doing it as a payback to the community.
Okay, thank you. I kind of want to just jump back with the three of you and to talk a little bit about, we've kind of been talking about harm reduction as a whole, but just digging in for a couple minutes to what distinct things there are about doing harm reduction in rural and small town spaces. So I think, we recognize that there's a lot about the practice that's the same, there's a lot about the sensibility that's the same, but the day-to-day can actually look a lot different, and there's some distinct differences in how we have to organize services or, kind of think about how we're reaching people. So I wonder if any of you can talk about that.
Well, organizing the services hasn't really been an option for us. I'm being glib, but it's not really been, we haven't really had the ability to travel and really have face-to-face contacts with people, which I think...
I would say, though, that, you were kind of alluding to doing a lot of your work through secondary exchange.
Through secondary.
And so can you just explain what that is for folks and why that's important? Because that's important in any harm reduction context, but I think maybe especially
in particularly in places where it's 2.5 hours away for many folks that use drugs, and they're living in very isolated communities. So what we do in the best possible situation is actually deliver to a secondary out in the remote areas. What we do in the not so great situation is that they travel the 2.5 hours to come to us and get the amount of harm reduction materials they need, the syringes and everything else. And they deliver to their group, and that group delivers to another group, and it just sort of, moves out. But if you've got areas that really don't have anybody that's connected to the exchange, you've got pockets of people that even now, when we've had syringe exchanges around for 20 and 30 years, they still don't have access, and they're reusing and many of the reservations don't. We haven't had the outreach personnel to get out to the reservations. There's a lot of people who are really suffering, and they don't get what they need simply because it's such a large area, and it's very hard to navigate, and there isn't a process yet or reorganize. So it's about having those connections, and so calling you the day before, I'll need 2,000, and arranging for somebody to be there and all those details. Again, some of those folks know how to make referrals, and some have good transportation and can bring people in, but it's still a large group of human beings that don't get to see that there really are things they need out there. They're very isolated. And so the practicalities are how to help people be less isolated and do whatever they have to do to get to that secondary exchanger or vice versa. So.
I just wanted to add a couple things, building off what Libby said. The first is that we often talk about a conflict between public health goals and law enforcement goals when it comes to drug use. And that is not abstract.
This has occurred to some people.
That's not abstract in a small town. So if you have a syringe exchange program in a small community and you're relying on secondary exchangers, you might be relying on less than 10 people to come to your exchange and take those supplies out into the community. And those are likely the same 10 people that the police are constantly trying to lock up because they're the ones who are selling or using a lot. And if they're locked up, they can't do harm reduction. And so finding a way to work with law enforcement around the need to keep people alive is a really important thing that has to be confronted when there isn't anyone else you can rely on if your main guys are in jail. And then the second thing that I wanted to mention, I hope Brandy has something to say about this, is that in California especially, we have to recognize the impact of history. And the reason that, a lot of the towns that we live in are in the places they're in is because 150 years ago, the people who settled this area killed the people who lived here. And that was not that long ago, and it still affects where people live and how they relate to one another. And if we don't keep that in mind, especially when we're dealing with isolated communities, especially when we're dealing with Native communities, then there's just going to be a barrier that's going to keep us from having those conversations at all.
Yeah, our genocide happened, I think, 112 years ago. There was a moon ceremony, and the men had left Indian Island, and the white guys came in and slaughtered all the women and children. And so we have some really recent and horrific things that have happened, and then, like most white communities, they then made everyone go out into a reservation where there's, now it's a food desert because we shut down the grocery store and there's no running water, and then our white system comes in and takes their children because we don't understand, because our white system is not culturally competent. So we just continue to put all this pain on tribal communities, and then there creates this barrier where why would there be trust to talk about these things? I was really honored to have been asked by the Yurok Tribal Opioid Planning Committee to come and do naloxone training. And we did a naloxone training and distribution, and we managed to distribute about 100 naloxone to 10 people, and 3 of them were children between 9 and 12, whose friends were already smoking heroin. So there was a lot that, where is that moment where you're like, oh, I need to work on some things inside, because I hadn't encountered that yet. But then I had to put my white privileged self away and realize that, oh, this isn't what's happening in town, this is what's happening, and this is real. And having youth that encounter those things and have the ability to make sure their friends don't die, that's critical. And then we can compound that when they come into town and our police say things like, go back to the reservation. You can find that on YouTube, Officer Goodall and Hubbard. They told a man who was by his car to go back to the reservation. But law enforcement is some of the biggest barrier in a small community. For example, many of them do not like us. And this morning, our program coordinator was coming across the bridges, saw 2 of our secondary exchangers being jammed up by the police. And when they were done, they came into Hatcher and said, hey, Officer Ross, once again, did this to us. We told them, hey, here's our consumer card, because we give them a card that says, these are my rights and I can carry this stuff. They usually tear it up, throw it on the ground and say, we don't care, and ticket them anyway. That makes it so that people throw their syringes on the ground, because why would you want to carry them? It makes it so that people don't have information, they're afraid, they're not coming to services, and for, law enforcement, that puts law enforcement at risk, because now people aren't going to be honest with you about what they have on you. So it's kind of just up for grabs what you might get when you're searching someone and they're afraid of you. That was a long ramble, but did I hit it?
Yeah.
I wanted to say something.
Yes.
Hi, my name is Marilyn Powell from Humboldt County. I'm a Hoopa Valley Tribal member. I'm on the Kamau board, which is the medical facility there. And one thing I just have to say is, this opioids just across the nation, and it's cutting through all races, all people. So I just wanted to say that we have a coalition going on in our reservation.
absolutely, and that's important.
Can I say something also? Sorry. Just to speak to the law enforcement pieces, I will be doing a session later today, and it will not be about educating law enforcement or anything like that. But Stephanie Tanaka from Alternative Sentencing. So I think the piece that's really going to be a great takeaway for most people here is because while law enforcement sometimes is a barrier, what we have to learn as harm reduction specialists is how we educate, how we speak to our law enforcement partners so that they understand the work that we're doing and how it can benefit the work that they're doing. So coming alongside them. And I think Plumas County, as Lindsay was stating, has done a really great job of that. We have a long, long way to go. But if you take anything away today about law enforcement, I want you to take away the fact that while we speak to our clients and the people that we serve daily, we also have to change our message to make sure our law enforcement partners understand the need as well. So, sorry. Thank you.
Is there any law enforcement officers here?
You know, I do not know the answer to that.
Can I say something?
Sure.
Hi, I'm Christina Dono, and I work in the Plumas County Behavioral Health Department. And I'm not a longtime Plumas County resident, but I've been here for 5 years, and I've worked in different areas in the county. I'm currently working in treatment as a substance use disorder counselor. And I have noticed a lot of improvement between the agencies, because a lot of my clientele are in the criminal justice system, they're on probation, they're involved with CPS cases, and those agencies are more into the abstinence piece, where, you know, bridging that gap between abstinence and the harm reduction, I've seen a lot of improvement in this county, like, as I said, just in the 5 years that I've been here. But that's my focus as an alcohol and drug counselor, is working with clients and people that are suffering from addiction, and they're expected to go towards abstinence, and there's a fear. But as I said, I think our partners with alternative sentencing, probation department, our CPS social workers, I think those conversations have been improving, and there's been a lot better communication about what would really helpful for our clients and their families.
Thank you. And we're out of time. So anybody have very final last words just to kind of wrap it up? The one recommendation you'd make for everyone as they dive into this conference and planning for the future?
Begin the collaborations that we thought we could never make.
That's great.
Plumas County Public Health Agency, growing healthy communities.